Good morning. My name is Mason Danika. I'm a fourth year medical student. And today I'll be discussing ligamentous and meniscal injuries associated with tibial plateau fracture. My objectives for today will include a review of the anatomy, epidemiology, and classifications of tibial plateau fractures. We'll also discuss the impact of soft tissue injuries associated with tibial plateau fractures. Finally, we'll focus on correlating advanced imaging findings with ligamentous and meniscal injuries in the acute setting, the integration of the recent literature on this topic. So we'll start with our case. Patient NR is a 47-year-old male who presented to the office as an outpatient 1 week after landing awkwardly on his right leg while playing basketball, sustaining an injury to the right knee. He was initially evaluated in an outside institution where x-rays revealed a bicondylar tibial plateau fracture. He now presents to the office to plan definitive management of his injury. Past medical and surgical histories were unremarkable. On examination, he was noted to have mild swelling with tenderness to the medial and lateral aspects of the right knee. He was neurovascularly intact and had limited range of motion secondary to pain and swelling. So here we have multiple views of the right knee displaying a bicondylar tibial plateau fracture with depression of the lateral and medial condyles, as well as a medial split in the coronal plane. You can also appreciate some significant lateral condylar widening, as well as posterior depression. CT scans are obtained at the outside institution prior to discharge to further assess for fracture patterns. Here we have axial, coronal, and sagittal views. You can see some significant lateral depression, as well as lateral widening. We also can appreciate posterior medial depression. In the sagittal view, we can appreciate the coronal split that resulted in an additional posterior medial fracture. So we'll start with some background information on tibial plateau fractures. These are periarticular injuries of the proximal tibia that are often associated with soft tissue injuries. They account for approximately 1 to 2% of whole body fractures, and they have an incidence of 10.3 per 100,000 annually. As for the mechanism of these injuries, they're most commonly from high energy traumas resulting from motorcycle accidents, pedestrians struck by motor vehicles, and falls from height, but they can also occur from lower energy mechanisms as well. The fracture patterns often result from a varus or valgus load with or without concurrent axial load, and these produce high energy shearing forces and axial compression. There's a bimodal age distribution, with high energy traumas being more common in younger patients and lower energy falls being more common in the elderly. Treatment consists of surgical open reduction and internal fixation, either in the acute setting or with an external fixator, followed by delayed definitive fixation, depending on the amount of soft tissue swelling. Other important factors that make treating tibial plateau fractures fairly difficult are the intra-articular components, as well as the associated soft tissue injuries, which we'll discuss further today. We'll briefly review some relevant anatomy for these fractures. Two plateaus form the inferior articular surface of the knee and are separated in part by the intercondylar eminence. The lateral plateau is convex and is slightly proximal to the medial plateau. This lateral plateau is the most commonly injured. The medial plateau is concave, and this medial plateau provides approximately 60% of the knee's load. Soft tissue injury is extremely common in these fractures due to the close proximity of many of the stabilizing ligaments of the knee and both menisci. Menisci sit directly on top of the tibial plateaus. The cruciate ligaments insert on the articular surface of the tibia, and the collateral ligaments of the knee also have close proximity to the plateaus. As for initial evaluation, as always, we'll begin with inspection. We need to look circumferentially to rule out any open injury, as well as to assess for the degree of swelling, which, as we mentioned, can determine surgical planning. Neurologic exam focuses on the function of the perineal nerve, which is vulnerable in these plateau fractures. The tibial nerve is also in close proximity and should be evaluated. The vascular portion of this exam is especially important due to the close proximity of the popliteal artery. Pulses must be palpated and are almost always followed by ABIs due to the risk of popliteal artery transection. Compartment syndrome also must be considered whenever the compartments are firm and not compressible. When suspicious of the presence of tibial plateau fractures, the initial imaging will be x-rays. The plateaus in the lateral view will be superimposed onto each other. However, the convexity of the lateral plateau, as well as the concavity of the medial plateau, allows you to differentiate between the two. When assessing for fractures, you can look for disruption of the convexity, as well as disruption of the concavity of the medial plateau. Also look for depression and any displacement that might be present. It's also important to note that there's between 5 and 15 degrees of posterior sloping of the plateaus. This can lead to an underprediction of anterior plateau depression and an overprediction of posterior plateau depression. Additionally, CT scans should be obtained because they more accurately assess for fracture lines, and they can also more accurately measure the amount of depression and displacement if it's present. There's multiple classification systems for tibial plateau fractures, with the most common being Schatzker classification. This system is based on a two-dimensional approach of the fracture, and it's based on X-rays. Type 1 is a split fracture of the lateral column. This is more common in younger individuals who have a denser cancellous bone that's more effectively able to resist impaction. Type 2 is a split depression fracture of the lateral column. This is the most common type. Type 3 is a pure depression of the lateral plateau. Types 4 through 6 often occur from higher energy mechanisms. Type 4 is an isolated fracture of the medial column. Since this medial tibial plateau is denser bone than the lateral one, a higher force is often required for these fractures. These are often fracture dislocations with the potential for significant neurovascular complications. Type 5 is a bicondylar fracture. And type 6 is also a bicondylar fracture, but with metaphyseal to aphyseal disruption. Our patient best fits the type 5 Schatzker classification, but as we'll discuss, there's more aspects to these fractures that need to be considered. As our patient's posterior component demonstrates, the Schatzker classification doesn't always perfectly classify these fractures. Whole and more is another system that's commonly used and especially useful when fractures don't fit the traditional Schatzker classification. In this system, type 1 is a split fracture in the coronal plane. Type 2 is a fracture of the entire condyle. Type 3 is a rim avulsion. Type 4 is a rim compression. And finally, type 5 is a 4-part fracture, in which the tibial eminence is separated from the tibial condyles and the tibial shaft. 3-column concept is another important system that was developed due to the need to more effectively describe posterior tibial plateau fractures, such as ours. This is utilized on the basis of CT scanning. This classification divides the tibial plateau into a lateral column, a medial column, and a posterior column, which is further split into medial and lateral parts. It's a valuable classification because it can more effectively guide choices for surgical approach and for internal fixation methods. So now we'll talk a little bit more about the associated ligamentous and meniscal injuries in tibial plateau fractures. Due to the high energy shearing forces and compressive stress in these fractures, there's a high susceptibility to soft tissue injuries. Meniscal injuries have been reported to have an incidence between 39 and 99%. The incidence of cruciate ligament injuries has been reported to be between 16 and 57%. And collateral ligament injury is also common, with one study by Gardner in 2005 finding that 29% of operative tibial plateau fractures had complete LCL tears and 32% had complete MCL tears. These injuries can result from the direct external trauma or from displaced bone fragments. So a brief overview of the treatment of these injuries. The majority will require operative fixation. Candidates for non-op treatment are minimally displaced and minimally depressed fractures that are stable to varus and valgus alignment. The gold standard for treating these fractures is an open reduction of internal fixation using a combination of screws, plates, and or bone grafting, depending on the fracture pattern. As I previously mentioned, if the degree of swelling is significant, application of an external fixator followed by delayed definitive surgical intervention is an acceptable option. The main goals here are to restore congruence of the articular surface, as well as ensuring mechanical alignment. However, these fractures can pose a surgical challenge when occurring with soft tissue injuries. The presence of these soft tissue injuries is important because it can alter surgical treatment and the rehab plan. So as for the treatment options for these soft tissue injuries, meniscal injury can be addressed with suture repair or meniscectomy. Cruciate ligament injury poses a challenge, and treatment often differs between bony avulsions and mid-substance ligamentous injury. Avulsion injuries can be conservatively managed or can be addressed by ORIF or arthroscopically assisted reduction of internal fixation. Mid-substance ligamentous injuries have classically been treated with delayed reconstruction of the ACL or PCL. Lateral ligament injury can be addressed simply through the use of a hinged knee brace. Operative options include primary repair or ligament reconstruction. Overall, there's still a great deal of controversy in the literature pertaining to methods of treatment for specific injury combinations. However, it has been shown that treatment of these associated injuries at the time of surgical fixation can have a positive impact on the overall outcomes. So why is this important? Failure to address these ligamentous and meniscal injuries can result in persistent knee instability and long-term deficits, such as increased post-traumatic arthritis and decreased satisfactory outcomes. Treatment of meniscal injuries at the time of surgical fixation has shown good clinical outcomes. One study by Foreman in 2013 showed similar functional outcomes in patients with acute meniscal repair with these fractures compared to those without meniscal tears. Park in 2017 also showed favorable outcomes with meniscal repair during ORIF. Recent case studies have reported that combined surgical management of tibial plateau ORIF with ACL reconstruction is a safe option with good short-term outcomes. Overall, pre-op knowledge of these injuries can aid the surgeon in determining whether to intervene surgically, whether to make an arthrotomy during fracture fixation, or whether or not to utilize arthroscopy. These promising findings highlight the importance of identifying these injuries and adequate surgical plan. So how do we diagnose these soft tissue injuries? Clinical diagnosis is often difficult given the amount of pain, swelling, and limited range of motion in these fractures. X-ray and CT scan detect fracture patterns, but have not classically been used to diagnose soft tissue injuries. MRI would be the most effective way to diagnose ligamentous and meniscal injuries. However, this is rarely used in the setting of a acute tibial plateau fracture. This is likely because it's a time-consuming examination, has a high cost, and has a limited availability. Many surgeons check the integrity of these structures intraoperatively. However, there's still a lack of a gold standard for diagnosing intra-articular and soft tissue pathology preoperatively. Recent literature is focused on whether there are useful parameters on imaging that's already a part of our initial workup for tibial plateau fractures to better predict soft tissue injury preoperatively. So we'll start with this study by Gardner that was published in 2006, which has served as kind of an early landmark study on this topic. The purpose of this study was to determine whether plain radiographs could be used to predict the incidence of meniscal and ligamentous injuries. Gardner evaluated patients with Schatzker type 2 fractures and used plain radiograph to measure both lateral plateau widening and depression. MRI was then used to assess for soft tissue injury. The study found that lateral meniscus was found to be injured in 83% of fractures when depression was greater than 6 millimeters and widening was greater than 5 millimeters. The study was a major step in the assessment of using radiographs to predict meniscal tears. However, in the years following, concerns persisted regarding the accuracy of radiographs to assess the risk of soft tissue injury. This has led to further investigation in recent years into the accuracy of CT findings to predict these pathologies. So in my review, I found a few papers that determine multiple different CT findings can be useful to predict these injuries. The first study is by Kolb out of Germany in 2018. This study evaluated the influence of lateral plateau widening on the frequency of ligamentous and meniscal injuries. Lateral plateau widening and depression were measured on CT, and MRI scans were then used to assess for soft tissue injuries. The study found that increasing lateral plateau widening by an additional 1 millimeter was associated with up to a 40% increased incidence of lateral meniscus tears. Additional increase of lateral plateau widening by 1 millimeter was also associated with up to a 32% increase in the incidence of LCL tears. Here you can see that the study revealed a significant correlation between the amount of lateral plateau widening and the overall quantity of soft tissue injuries, the incidence of lateral meniscus tears, and the incidence of LCL tears. The study concluded that these findings are clinically relevant given that the knowledge of meniscal and ligamentous tears preoperatively may affect treatment and outcome. This makes the amount of lateral plateau widening a useful parameter to check in the acute setting. This next study, published in Injury this past June, evaluated whether the extent of articular impaction and displacement, as well as the fracture location, were related to meniscus injuries. Plateau injuries were divided into 4 quadrants on pre-op CT, and maximum AID was measured. All patients then received arthrotomy to more accurately evaluate the integrity of the meniscus. Results of this study found that the mean AID for plateau fractures with meniscal injury was 12.48 compared to just 6.4 in fractures without meniscal injury. For every 1 millimeter increase in AID, there's a 21% increased chance of meniscus tear. The study also concluded that for the same AID and Anterolateral and anteromedial zone fractures had a 7.3 and a 5.6 times increased risk of meniscus tear compared to the posterior lateral zone. Overall, the lowest amount of depression was required in anterolateral zone fractures for patients with meniscal injuries. Study determined these values are useful in predicting pre-op meniscal tear without the use of MRI. They also concluded that one must pay close attention to the area of the greatest depression, since peripheral depression has an increased risk of meniscal tear compared to central depression. This last study from 2018 was a prospective study that also investigated meniscal and cruciate ligament injuries associated with tibial plateau fractures. The purpose was also to identify radiologic predictors on CT scan, and all patients enrolled in this study underwent arthroscopic exam after tibial plateau internal fixation. Results found that the menisci were considered to be traumatically injured in 52.9% of patients, with 90% of those injuries occurring in the lateral meniscus. Cruciate ligament injuries were found in 22.5%, with avulsion fracture being the most common injury. Authors concluded that the most appropriate cutoff that points for lateral meniscus tear was 6.2 millimeters of depression. Patients with greater than 6.2 millimeters of depression had a fourfold increased risk of lateral meniscus tear. They also determined that the most appropriate cutoff for ACL lesions was 5.7 millimeters of lateral condyle widening. The study concluded that lateral plateau depression and lateral condylar widening can help you predict a higher risk of meniscal and ACL injury, providing guidance to the surgeon to look for and be prepared to treat these injuries. As for the treatment for our patient, he was brought in through same-day surgery, underwent ORIF using a combination of lateral and posterior plating, as well as bone grafting. Given the amount of depression he had on his pre-op CT scan, the patient had been advised preoperatively that he likely did have a lateral meniscus tear. This tear was noted intraoperatively and was repaired using sutures. The patient left the same day and will remain non-weight bearing for an additional 10 days. So in summary, tibial plateau fractures can be difficult injuries to treat given the intra-articular nature of these injuries, as well as the associated soft tissue injuries. It's imperative that providers have a high suspicion for meniscal and ligamentous injuries in patients with surgical tibial plateau fractures. These injuries can alter management and long-term outcomes. Finally, the main point that I'd like to drive home is that we can use imaging that is already a part of our initial workup for tibial plateau fractures to better predict soft tissue injuries. Pre-op CT measurements, including the amount of plateau depression, condylar widening, and fracture location, can help us predict a higher risk of meniscal and ligamentous injuries and can provide guidance for us to look for and be prepared to treat these injuries. These are my citations.
I thought that was a great presentation. I learned something because I don't do adult trauma, obviously. I was wondering about two things. You mentioned external fixation as a temporizing measure for swelling. About how long is the interval between the application of the external fixator and the definitive fixation?
In my review, the most common, I believe, was around 2 weeks, anywhere from 10 days to 2 weeks.
Any reason why you think that time frame is appropriate?
I'm not sure. I didn't come across anything specific in my review, but just to give it enough time for the swelling to decrease, I think is probably the reason why we give it that much time.
Right. Why not go longer?
We probably don't want it to get too stiff in that fixation. You want definitive treatment.
Right. The knee's not moving. Okay. And the fracture starts to heal and makes it difficult to go back and get your fixation. Okay. So that's the right titrated amount of time to have the swelling go down and to make sure that the fracture isn't too sticky that it's hard for you to, especially in a split press, to try to elevate fragments or bring things back together. Good. Another question is, can you go back to your case?
Mm-hmm.
And then just use the classification schemes that you described to us to kind of classify the case that you described.
Sure. So for our Shasper classification here,
probably called Casting. Yeah, Casting X-rays.
Okay.
Yep.
So like I said, it doesn't perfectly fit, but in my opinion, it best fits a type 5 if it's bicondylar tibial plateau fracture, and there's no metaphyseal or diaphyseal association.
Right.
As for the whole and more, I think it best fits type 1, just because there is the coronal split and there's a posterior medial fragment.
Right.
And then As for the 3-column concept, it really does, there's pathology in the lateral and the medial columns and the posterior columns. So I believe when we went in the surgery, we did have a lateral incision and a medial incision to treat kind of both sides.
Yeah, agreed. And then the last question I had for you is, you mentioned delayed reconstruction of the cruciate ligaments, and certainly after you've done this fixation, you're not going to be too rough with this. You know, varus valgus stress is obvious. But say you find after you reconstruct and you have suspicion of these cruciate ligament repairs, why don't you do an acute reconstruction of those? And then if you do it delayed, when would you do it?
I believe the reason why I wouldn't do it right away is because there's still like the fractures essentially can kind of just get in the way and make it very difficult to repair.
Right.
I believe most of the literature I read was that they would wait for union to occur and then they would go on to repair or reconstruct the ACL or PCL.
Right. So you said exactly the right answer. Okay, it's reconstruction, and in order to have an effective reconstruction of your cruciate ligaments, you need to pass a graft through the knee. Number one, you want your full motion back, so you're not working on a stiff knee that's now going to get stiffer. Okay, so you want to get all your motion back before you reconstruct them if you can. And then number two is you have to have bony tunnels that you can pass those grafts through for fixation. So it's allowing the bone to heal to be able to drill those tunnels. Okay, good.
So is there any difference between treating a fracture and dealing with a meniscus later on?
Yeah, there's
Treating it.
yes. So some of the outcomes that I read show that if you were able to treat the meniscus at the same time as Plateau or ORIF, it did have better long-term outcomes. That was more so for the lateral meniscus. The medial meniscus seemed to still be somewhat controversial. There wasn't too much literature specifically on treating the medial meniscus, but the lateral one, I believe, is if you're able to repair it at the time of initial ORIF, that does have improved long-term outcomes. I think the main finding that I found was decreased amount of post-traumatic arthritis if you're able to repair it.
So it seemed to me that if you repair the fracture, or able to get a MRI, in a reasonable time frame, it probably shouldn't. I mean, obviously, you don't want to leave a bad disc tear and that walking on it for a couple of years, but it seemed to me that probably wouldn't make that much difference as long as you recognize the possibilities. Or the other thing is, why worry about getting MRIs? Why don't you just take a look at all of this? Okay. Why waste your time, with all of these studies and just, make a little look at it. It's there, fix it.
Yeah, I think that is a common way to do it. I think the arthrotomies can be very commonplace in these. I think the thing that I would do now is just kind of based off like these pre-op CT findings. If you do see a large amount of depression or condylar widening, then okay, I definitely will make the arthrotomy. If there's like really no displacement or depression, or it's not too bad, then maybe you consider not doing arthrotomy. But
Mason, I thought that was a great talk. Really, you understand the material very well. And my question's very basic, but as you're sitting in the exam room discussing different treatment options with the patient, what about if we just did nothing here? What would you tell them would be the problems or the potential things that could happen if we just kept this in a brace or a cast and let it heal?
do you mean for the fracture or?
For the fracture.
Yeah, so they would have like significantly more increased chance of post-traumatic arthritis if that were the case. Like in my review, I found that if you don't have good varus or valgus alignment, then you have significantly worse long-term outcomes in that regard, as well as just intra-articular reduction that can also play a role.
How would you say that to a layperson?
Yeah, I would say that we needed to go in essentially and fix these fractures and any associated pathology, because if not, your knee won't have the correct alignment, and that can actually make it way more difficult down the line for you to just have your basic daily activities because of things like arthritis, poor alignment, and other things.
It's all about joint congruity.
Right. But doctor, can I have a knee replacement then? I don't want surgery now, I'll have it later. What do you say to that?
you can have a knee replacement later. But I believe like you don't want to start doing knee replacement, especially if this is in a younger patient that's in his 40s that got into a car accident. You may try to avoid the knee replacement right away. That may be something that you have to do down the line. I did see that a lot of these patients, I think it was 1/3, have post-traumatic arthritis. But I think the amounts of the incidence of total knee arthroplasty after was around 6%.
Yeah.
So
So
it is something down the road.
it could appear down the road, but if you don't operate on them now, then you can have a knee that doesn't have good bone stock for appropriate primary knee replacement. And you may also have issues with a knee that's so stiff that you don't get a good result from a total knee as well. So that's really where the counsel comes from. Good, thanks, Mason. That's cool.
Thank you. We sell these for the kids with clubfoot as kind of a little bracing buddy, so I don't want to.
Yeah.
Good morning, my name is Danika. I'm one of the 4th year students as well, and today for my presentation, I'll be talking about congenital clubfoot and factors guiding the decision to perform a heel cord tenotomy. So the objectives of my talk, so today I'll be providing a review of congenital clubfoot deformity and treatment, discussing the shift in the treatment paradigm of clubfoot over the last few decades, reviewing the clubfoot severity classification system, specifically looking at the Piranesi and Neurologic scores, and also be evaluating the literature surrounding factors predictive of the need for an Achilles tenotomy. We'll start with the case. Our patient is a 1-month-old male, X35 weeker, born via normal spontaneous vaginal delivery at home to a 28-year-old G3P1 mother, who then subsequently received care in the NICU for about 17 days with 4 oral intake. While in the NICU, he was found to have bilateral foot deformities, also hypospadias and ventricular septal defect, and orthopedic surgery was actually consulted during the NICU admission with further evaluation of his noted foot deformities. Past medical history is as mentioned, and maternal history again is mentioned, but the mother was also noted to have intrauterine growth restriction during her pregnancy and was also followed by a high-risk OB clinic for placenta effreta. There was no other relevant past surgical history or social history or any meteorologies. So generally on physical exam, the patient appeared to be well appearing, resting comfortably. On musculoskeletal exam of note on his left foot, he was noted to be supinated without any significant cavus or finus deformity, and his toe flexors noted to be tight, and otherwise his foot was supple and flexible. On his right foot, his foot was supinated with significant cavus and a finus deformity. The lateral border of his foot appeared to be slightly more curved compared to normal, and there was no posterior medial crease that was noted, and the foot is again supple and flexible. No other abnormalities were noted on his general musculoskeletal exam. On neuro exam, he was able to actively dorsiflex his toes bilaterally, and just general vascular exam, his extremities appear to be well perfused. We'll talk about the initial treatment and follow-up care for this patient. So just in review, he's a 1-month-old male infant who was found to have a moderate right-sided clubfoot deformity and a left-sided metatarsus adductus. The right-sided clubfoot was noted to have a Ignacio score of 10 upon initial exam. For his initial treatments, the patient was actually placed in bilateral, well-molded, long-leg plaster cast with a right-sided clubfoot that was cast following Poncetti principles. And for his follow-up care, so we'll start with the right-sided clubfoot. This patient continued to come in for weekly evaluation of his clubfoot, serial manipulation, and Constantine casting that was done weekly. He's actually currently on his 6th and final cast that will be maintained for a period of about 3 weeks before he begins the bracing phase of treatment. And an Achilles tenotomy was actually not performed in this patient, as he was actually able to dorsiflex his ankle above 40 degrees above neutral. And for his left-sided metatarsus adductus, so he was placed in a single long leg cast for about 1 week. And the patient's family was then encouraged to continue some daily gentle stretching of both the foot and the toes to help aid in the resolution of the deformity. And we'll just continue to observe him in clinic. A little bit of background about congenital clubfoot. It's actually one of the most common congenital musculoskeletal conditions affecting infants, with instances of about 1 in 1,000 that it affects. There is a male to female ratio predominance with about 2 to 1. 50% of our patients actually have bilateral involvement, and the cause is actually currently unknown. There is the thought that there is a genetic component to congenital clubfoot with a familial occurrence of about 25%. And it may actually be diagnosed in utero during typically the second trimester prenatal ultrasound or at the time of birth. Some associated conditions, so there's actually quite a few, but some of the more common ones are things like arthrogryposis, myelodysplasia, tibial hemimelia, muscular dystrophy, amniotic band syndrome. And interestingly, actually, for a few of our clubfoot kids, regardless of the etiology of what causes it, whether it's idiopathic or associated with the syndrome, have actually been found to have anterior tibial artery hypoplasia or absence. So clubfoot, actually, when we talk about the deformities that are kind of involved in this pathology, it's actually a complex deformity of structures below the knee. So it actually kind of combines both muscular and bony deformities. And typically the characteristic deformity pattern that we talk about, we can use the acronym CAVE to kind of remember what that encompasses. The C stands for cavus of the midfoot, and that's typically due to the tight intrinsics of the foot, the FHL and FDL. Adductus of the forefoot, typically due to tightness of the tibialis posterior. Varus of the hindfoot, which is usually due to contractures of the Achilles tendon, tibialis posterior, and tibialis anterior. And Aquinas of the hindfoot, which is typically due to a contracture of the Achilles tendon. We also see some associated bony deformities, so things like medial and plantar deviation of the talar neck. The calcaneus is typically in varus and rotated medially around the talus. We also see medial displacement of the navicular and the cuboid. And the first metatarsal is actually also noted to be in more plantar flexion relative to the others. The affected foot is also commonly found to be smaller than a normal foot, and there's also associated calf hypoplasia on that side as well. And usually when we talk about clubfoot kind of compared to our other foot deformities in children, we like to think about a packaging versus a production problem. So clubfoot is actually considered a production problem. It's something that kind of happens in utero in our children that kind of causes these muscular and bony deformities to take on the shape of the clubfoot. And this child also had metatarsus adductus, so that's what we call a packaging problem. So something kind of in utero, whether it's a problem with the amniotic fluid levels or the shape of the uterus, for example, that actually causes some growth restriction type problems that we see in these children. So some considerations for physical exam, it's actually really important for us to determine whether it's a clubfoot deformity or something else that we're talking about, just because the treatment is very different for these. So how to kind of figure out, is it even a clubfoot in the first place? So we like to look at things like stiffness and positioning of the forefoot, the midfoot, and the hindfoot in these children. We look for the presence of any abnormal or deep foot creases. We also like to look at the range of motion of the feet, especially focusing on the ability of the child to dorsiflex their ankles and also abduction of the midfoot. We also check for lack of active ankle or toe dorsiflexion. So this is actually something that is commonly missed in our exams, but can actually potentially indicate the presence of a neurologic etiology of their clubfoot, usually due to like an idiopathic peroneal nerve palsy. We also like to check for any pressure sores or skin problems that may also need to be kind of addressed and taken into consideration when we're doing the cast for the weeks that they'll be undergoing that treatment. And we can actually use our scoring systems that we have to kind of help guide our assessment of clubfoot. So today I'll actually be talking about the Piranesi and Neurologic scores, which are two of the more common ones that we use. We'll start with the Piranesi score. So the Piranesi score was actually developed by Dr. Shafiq Pirani to assess clubfoot at both the initial presentation and help monitor the treatment progress. It's actually comprised of two different scores. We have a midfoot and hindfoot score that can each receive a maximum score of about 3. And you can actually combine both these scores to give you the final Piranesi score with a maximum severity of 6. There are actually individual components that are divided into a scale from 0 to 0.5 to 1. So I'll actually kind of review those briefly. So looking on the left, we have the midfoot score. So you'll see that there are 3 components there. There's the presence of the medial crease. We look at the curvature of the lateral border of the foot. We also look at the lateral head of the talus to see how reducible the navicular is over this bone. We also have the hindfoot score. So there are 3 components there too. We have the presence of the posterior crease. We have the empty heel pad, kind of looking at whether you can feel the calcaneus in the heel pad or not. And one of my mentors taught me a very easy way to kind of look at this. If you take your finger and kind of feel your chin, you can actually feel your bone pretty well. And that would be something that we would classify as A0 because you're able to feel the calcaneus in the heel cap. 0.5 is kind of like feeling the tip of your nose and a little bit softer and not as easily palpable. And then if you feel your thenar eminence, that's kind of your 1 score. It's very hard to kind of feel the bone structures underneath. It's very soft, so hard to feel the calcaneus in the heel cap. And then we also look at rigid Aquinas, which is the ability of the ankle to dorsiflex to neutral or past neutral. So 0 is the child is able to dorsiflex above neutral, able to get to just neutral is a 0.5 score, and then 1 is going to be you're unable to get the ankle to even neutral. The second system here that I'm going to be reviewing is the Neurologic score. So this is another classification system that uses a 20-point scoring system. By actually assessing the residual deformity after we apply a gentle corrective maneuver. The severity of the deformity is then graded on a scale of 1 through 4. So grade 1 is typically our benign clubfoot deformity, which is about 5 or less on the total score. Moderate clubfoot deformity is going to be 6 to 10. Severe clubfoot deformity is 11 to 15, and then we have a very severe clubfoot deformity, which is 16 to 20. So some of the components here, they do overlap a little bit with the Piranesi score. So we see you're looking at the ability of the ankle to dorsiflex, looking at the heel varus component. Something that we talk about is called the calcaneal peel unit, which is essentially all of the structures other than the talus, looking at the ability of the foot to kind of invert and invert around the talus. And you're also looking at the adductus component as well. We kind of give that a score based on 1 through 4, depending on the degrees of which the foot is able to do that. And then some other characteristics that we look at are like posterior crease, medial crease, the cadence of the foot, and also just general muscular condition. We can't talk about clubfoot without talking about Dr. Ignacio Poncetti. So Dr. Poncetti was actually one of my mentors. So I have a picture of him here, also his famous green book that can revolutionize our clubfoot treatment today, and a picture of an old internet browser. So you're probably wondering why or how all of these are connected, but clubfoot treatment was actually revolutionized by Dr. Poncetti in the 1950s. And Dr. Poncetti's careful studies of the foot actually allowed him to kind of understand how these structures are all connected with each other, how movements of certain positions of the foot can actually affect movements elsewhere in the foot, which is something we call kinematic coupling, and how certain manipulations can help guide the foot to actually achieve a corrected position. So before Poncetti casting and the manipulation method that we're talking about, invasive joint releasing surgeries were actually the standard of treatment for our clubfoot kids. And the long-term results were actually not as great. So studies that come out that show that only 27% of our patients actually have excellent and good long-term results. 73% actually tended to have more fair or poor outcomes. So they have things like severe stiffness and also just severe pain as well. So Dr. Poncetti, since the 1950s, was actually trying to kind of spread the word about the method that he revolutionized, but it wasn't really until the late 1990s, almost 40 years later, that the Poncetti method actually slowly started to begin gaining acceptance. This was kind of as the rise of the internet started as well, and parents were trying to kind of share more about what are other treatment options outside of surgery that we can do for clubfoot correction. And so as people kind of went to Dr. Poncetti's clinic at the University of Iowa, started sharing on early internet forums, that started being spread with the provider and parent community. That's actually how we have the start of the Poncetti method today, and that kind of increased through the years too. So we'll talk about Poncetti principles. So Poncetti casting actually involves a series of both manipulations and casting that starts within the first few weeks of an infant's life. This usually allows for gradual correction of the clubfoot deformity through both serial manipulations and casting, and allows for the displaced bones to actually be brought into a proper alignment. It allows for stretching of the dorsal and medial ligaments, and we also see joint surfaces that are progressively remodeled in this fashion too. The manipulation itself, again, is based on the understanding of that kinematic coupling of the foot and ankle movements. So typically when we do this, we like to stabilize the talus, which provides that pivot point around which we can abduct the foot. We manipulate the foot with a supination and an abduction force, and we tend to hold this correction usually for about 30 to 40 seconds a few times. And then that's going to be followed by our cast. So that is something that we're going to be applying weekly therapy as well. It helps kind of immobilize the foot and stretch these tight tendons, ligaments, and joint capsules. So the goal of the first cast is actually to correct the Achilles deformity, and we do this by supinating the forefoot and elevating the first metatarsal. This also helps to address some of the midfoot inversion and also heel varus with a gentle abduction force. The subsequent casts are then focused on correcting the midfoot inversion and also the heel varus. And through these casts, we tend to achieve a neutral position of the heel and also about 50 to 60 degrees of midfoot abduction. And the final cast in most cases is usually after an Achilles tenotomy, and it's usually maintained for about 3 weeks. We focus on maximal dorsiflexion and abduction to correct the rigid ankle Aquinas. And this also helps to improve any residual midfoot abduction that we need, and in case the heel is invalid, helps to correct that too. Typically, our patients require about 4 to 6 casts. After casting is going to be the bracing phase. This is really where your patient counseling is going to be super important, where patients are going to be fitted with a foot abduction orthosis. It's typically worn about full-time or 23 hours of the day for the first 3 months, and then we transition to just nighttime and naps for about the next 3 to 4 years. So treatment actually kind of extends pretty long for these kids. And that kind of helps to just provide maintenance of that initial correction that we achieve through Constantine Casting. It should also be noticed that the clubfoot relapse is actually not uncommon in our kids. It's reported to be anywhere from 11 to 50% in the literature. And so they might actually need additional rounds of Constantine casting and may even need additional surgeries like the tibial anterior tendon transfer, depending on the actual type of deformity that relapses, a repeat tenotomy, or even more invasive surgeries, depending on the severity of the foot. So we'll talk about what the percutaneous Achilles tenotomy actually looks like. It's a minor surgical procedure that can be done safely in an outpatient office setting. For the procedure, you just need local anesthesia. Typically, a scalpel blade with the blade up is going to be inserted on the medial side, parallel to the Achilles tendon, about 1 centimeter above the calcaneus. The blade is then rotated gently to cut the tendon completely, and you usually hear and feel a pop, and that usually tells you that you transected the tendon. The foot actually immediately after doing the tenotomy should be able to actually dorsiflex about 10 degrees or more. So the Achilles tenotomy itself actually allows for correction of the rigid ankle Aquinas after you correct the other concomitant deformities. The Achilles tenotomy has been reported to be needed in about 70 to 80, and even sometimes in the literature up to 90% of the patients actually needing this procedure before we apply the final Poncetti cast. So in terms of how we decide which patients need a tenotomy, typically we like to talk about our patients who achieve a 15 to 20 degree ankle dorsiflexion after correction of other deformities likely don't need an Achilles tenotomy. But I was wondering, are there any other factors that we can look at throughout our patient's treatment that can help guide our decision to actually perform this tenotomy? So that's going to be the focus of the rest of the talk today. So one of the earlier articles that I found by Dr. Scher's group that was published in 2004 in JPO actually looked at the need to predict the actual need for tenotomy at the initiation of Poncetti treatment for our children. And it was a prospective study of about 50 club feet and 35 patients who were assigned both the Piranesi and Ignacio scores throughout their treatment. And tenotomy was actually performed in about 72% of these children, especially if they weren't able to dorsiflex their ankle to 15 degrees above neutral. And so the first figure we see on the left, so this actually compares the rate of Achilles tenotomy stratified by the severity of their initial Piranesi score. So they actually found a significant difference in the group that scored Piranesi score 5 or greater, which is a pretty severe clubfoot deformity at initial evaluation. And you can see that about 85.2% of these kids actually required a tenotomy before the final cast. And the second figure on the right, so that is very similar. It's looking at the rate of Achilles tenotomy that's stratified by the initial Ignacio score at initial evaluation. And they did find, again, a significant difference in the group that scored a grade 4 or very severe clubfoot deformity. They were the ones who tended to need an Achilles tenotomy again for the final cast, with 94.7% of those patients actually undergoing the procedure. And when they analyzed the individual components of the Piranesi score, they actually found that those who had a more severe posterior crease, an empty heel, and also rigid Aquinas score were the ones who were more likely to actually require a tenotomy than those that didn't. The second study here was actually done in 2015 and published in JPOB by Dr. Cadence group. It actually expanded on the results of the first study we just talked about. This was a retrospective study of 108 puppy in 74 patients, so a higher number of people that they actually studied in this research. And in this one, they scored the children based on a Piranesi classification system and looked at their scores kind of throughout treatment. And tenotomy was actually performed about 85.1% of children. Again, looking at the kids who weren't able to dorsiflex their ankle to above 15 degrees above medial. So they found in the study that the sex of the child, affected side, whether it was right or left, and the presentation day from initial treatment were actually not found to be significant factors that affecting the need for Achilles tenotomy. They did find the unique number of casts that were needed for these children throughout their treatment, the Piranesi score at the initial time of evaluation, and also percentage change in actually Piranesi scores throughout their treatment were found to be significantly correlated to the need for tenotomy. They found that the cutoff scores, similar to the other study, for the need for an Achilles tenotomy was actually a Piranesi score of 5 or above. So again, are very severe clubfoot deformity kids. And the probability of actually requiring an Achilles tenotomy was 12.5 times higher in our babies who had an initial Piranesi score of 5 or higher. So subsequent studies, again, and these are two examples, but there's so many that have actually demonstrated, again, significant positive correlations between the number of casts required for correction and also initial Piranesi score at initial evaluation with the need for an Achilles tenotomy. And this study here, so this was by Dr. Poncetti group, published in 2018 in International Orthopedics. So this was a prospective study where they compared both the Demeglio and Piranesi score in their ability to predict the number of casts and also the need for tenotomy and clubfoot treatment. And here they studied 91 clubfoot and 54 patients who were both assigned the Demeglio and Piranesi score throughout treatment, with tenotomy performed about 82.4% of clubfoot. Again, if ankle dorsiflexion was less than 15 degrees above neutral before the final cast. And it's shown by the ROC curves here, which represent the correlation between the Demeglio and Piranesi score with the need for tenotomy. And looking at the calculated area under the curve or AUC, the Demeglio score actually showed a slightly better performance compared to the Piranesi score in predicting the need for tenotomy in these children. However, they didn't actually find a significant difference between the two groups, but did note that the Demeglio score was a little bit better in predicting this need. They also found that there was a good correlation between the Demeglio score and Piranesi scores and initial presentation in predicting the number of casts these children needed throughout their treatment, with slightly higher performance again of the Demeglio score. And they think this can actually be explained by the heel varus component and muscular abnormality components of the scores. These are actually specifically not looked at by the Piranesi score, but they did find that there's a significant contribution of those two metrics to the predictive model of the Demeglio score and actually predicting the need for a tenotomy in these children. So in summary, kind of looking at our consensus for practice and also available evidence for performing an Achilles tenotomy. So remember, again, we like to keep in mind for our practices that patients who typically achieve under 15 to 20 degrees of ankle dorsiflexion after correction of their other concomitant deformities through casting and manipulation will actually likely need a tenotomy. Our clubfoot children with an initial Piranesi score of 5 or more, or a Demeglio grade 4, which is a total score of 16 to 20, are more likely to require an Achilles tenotomy before their final cast. These are typically our more severely affected children. And a child that typically tends to require more casts for clubfoot correction and also likely doesn't show a great change in their score throughout their treatment, likely due to a more resistant deformity, is one that's going to require an Achilles tenotomy more so than our other clubfoot children. And so kind of putting that all together, some of our key takeaways to keep in mind when we see these children in clinic. Scoring systems and physical exam for our clubfoot patients can actually help our providers make these decisions regarding the need for an Achilles tenotomy. And so because of that, it's actually really important for us to perform a thorough physical exam each time that we see them at their visits and practice good documentation of these as well, just so that we can consider changes throughout the course of their treatment before making this final decision. These are my references. I also have my email listed. I actually did research here last year at Stanford working with the pediatric orthopedics group there on congenital clubfoot. So always happy to talk about anything related to clubfoot. Thank you.
Danica's mentor at Stanford is Steve Frick. And Dr. Frick, actually, I got to know him very well. He was the president of POSNA a couple of years ago. And we have this international pediatric orthopedic symposium every year. That's a very hands-on skills lab where you get to work with people who have skills with this. And I had the chance to do a clubfoot lab early on in my career with Steve Frick and Matt Dobbs, who are like two of the leading minds, both studied under Poncetti, and really kind of changed my thinking. Club feet, there's very much an art to it. And I think you have to really understand the components of deformity. And it took me a while to appreciate it. You have to actually see your results. I had a lot of kids who had recurrent cavus later on that I had to go and do plantar fascia releases. And what I really came to appreciate is how important it is to really watch carefully to get the cavus corrected. My question for you, Danika, you touched on some of it. The difference between the ability and what I was always taught is that the outcomes of club feet were not well predicted per se by the severity of the Demeglio or the Piranesi score. Piranesi score came along first, Demeglio came along second. So a lot of the literature reports Piranesi. I use Demeglio. I think Dr. Bo uses Demeglio as well. I think everyone in our group does. And I like the Demeglio score a little bit better because it focuses on the reducibility of the talonavicular joint, which is really the focus. We're trying to pivot around that point on the foot, and that's really your fulcrum, okay? I have always thought that you have to have a good reason not to do a heel portinotomy, okay? Because I feel like so many of these kids don't correct. But I had the fortune of seeing the patient you described in your case on Tuesday, and I asked Dr. Ishmael, whose patient this is, let me take a look. I know you're listening, Terry. And I actually was really impressed with how much dorsiflexion there truly was, because I hadn't seen a kid quite like that, because many of them have been so stiff, and many times I've regretted not doing it and gone back and done it later on, okay? But my question for you, Danika, is what do you think it is about the Demeglio score in that operating curve that you reported that makes, you mentioned taking into account the condition of the muscles, which I think is important. But what do you think it is about the Demeglio score that's a little different than the Piranesi score that helps predict heel portinotomy?
I think, so I actually mentioned a little bit in that study too. So there were two components that we typically talk about in the Demeglio score that maybe aren't really addressed in the Piranesi score. So that's the heel varus component and also the muscular abdominality. I think those are two that are important for us to consider kind of looking forward to whether they need portinotomy or not. And also the Piranesi score, of course, it is a little bit earlier. Tends to kind of look at it looks at some of the similar components, but maybe not to the degree that the Demeglio score does. So we saw that there were more classifications looking at the Demeglio score with certain angles for specific deformities. We don't really see that in the Piranesi score. I kind of just generally classify as like a moderate, severe, and just a mild deformity.
Right.
And I think just better characterization of that with looking at specific angles, abduction or dorsiflexion is probably better for us to look at what is the need for this procedure.
Right. And I think you're exactly right. I think it has to do with the fact that when you look at a 20-point score, there is heavier weight in the score for the amount of Aquinas that you have and the amount of varus, because the correctability of the heel port is predicated also on how tight the heel, the calcaneus, and the varus is predicated on how tight the heel port is as well. So you're actually getting double weighting of the Aquinas in that Demeglio. What I always thought was the weakness of the Demeglio score, okay, is how it doesn't weight cavus as highly. And I think cavus is actually one of the bigger recurrence problems in my experience, okay? I am not an expert and not cast as many feet as the people who you were reporting today, but I always felt like giving it 1 point in a 20-point scale does not underscore how important it is to emphasize that correction, because the kids who come back and have problems in their feet, a lot of it can stem from that cavus, because that can contribute to the same supination that we misconstrue sometimes as the tibial weakness and transfer the tibial and think that's going to solve the problem. But if you haven't corrected cavus, the foot's still going to supinate. And so that's my critique, and something I look at really carefully as I gain more experience with these people.
I think some people you've seen casted by other people.
That's true, Andy. And I
think, you know, you correct casting the way you want to say taught us, and I'm older than Tom, okay, and I love club feet, okay, and I actually knew at that if you did a correct clubfoot casting, you shouldn't have a position.
Right.
That should be pretty easy to correct by casting. But the natural tendency is not to superimposed at foot position.
Right.
It's just inherently doesn't make sense, okay? Especially if you used to use the old kite type of technique. And as I've said many times, over the course of my few years, treatment of club foot has changed and evolved probably more than anything else. And someone who was in the office with me last week, I saw a 23-year-old girl that operated on 23 years ago, okay, significant significant open posterior medial lateral, which was the treatment at the time, has been worked very well. And the alignment of her feet, okay, so the alignment of her feet looked great. And she was walking pretty well. But what was her problem? She was having foot.
Yeah.
And the overall opponent was pretty good, but she was developing significant arthrosis of the joints. And treatment for that is the big difference between our treatment of posterior medial surgical procedures is that they deteriorated with time. I would say they don't deteriorate. So when I was first in practice, I was doing 20 or 30 movement procedures. That was very, very studied on the process of looking at people who do procedures. There are some very, very few people procedures. Once they're done,
Right. It's interesting when you do a PEDS fellowship now that the clubfoot surgical case is a highly coveted case, and 2 or 3 fellows will crowd into a room to see that case because it's done so infrequently. And honestly, I think that, Dr. Bowe and Dr. Laufer and Dr. Therian and Dr. Weissman did a great job of teaching me club feet. And, in the clinic here, I had a chance to try to cast some of those kids. But when I went to fellowship, I realized how much supervision you really need to teach that skill. And I was grateful to have that here. But I think it's an art that you really have to make sure you teach carefully to get it right. Because we've certainly seen a lot of bad results when it's not done correctly.
the downside of the percutaneous, of course, not.
There's always the risk of lengthening overcorrection, which is a possibility.
Does that occur in a 3-month or 6-month?
Typically not. I know that there's also
Yeah,
it really
I said
doesn't.
it doesn't occur.
Yeah,
Okay,
right.
so I mean, yes, with the literature. I never ever seen that. I asked Dr. Poncetti that particularly in eat. I think that he was so quickly, okay. It just doesn't make sense, okay? Lacerated or Achilles tendon, I mean, that can heal with conservative treatment. We know that even in adults. So why wouldn't it completely heal? It doesn't. Okay. Yes, I mean, yeah, it's a surgical procedure, okay, the results of, was your tibial aneurysm, okay.
So nerve
I
injury.
typically do these in the operating room. A lot of people do not. Years ago, I tried to do it in the clinic, and I found it were a couple of problems. One, with the family, okay. 2 is the areas of the end of the brain and things, okay. Kids who are still uncomfortable. And my biggest reason is that in the operating room, I can do a good denial. No, I don't. A lot of times when kids are screaming, the families are passing out, you just want to get it done and get out of there, And I don't think you do as good a job. I think it's more controlled, and it's even more importantly, okay, with the child asleep. Better. Anybody who tells me that they can run as good a cast in the office with a screaming child versus one that's asleep. So I do these, okay, in the and the other thing that I'm gonna ask you about this child, okay, is why wasn't this child casted before life? And are there results that starting casting at day 1 versus day 35 or 40, are there differences?
So this child actually did have a NICU admission, so I think I can also kind of talk about this with my experience talking to parents in my research here too. But I think it's pretty stressful also for our parents when they're dealing with other issues that our children have, whether it's NICU admission or something else that they might be born with, that it doesn't really require the need for us to start this on-site casting within the first day of life. I think they're sometimes told that by their provider, but doesn't necessarily do that. And in terms of the results, I'll have to kind of read that here myself, but I know that if you start within the first few weeks of life, there's really no significant difference that they found when you start day 1 compared to a few weeks later. So I think that's also something that we can probably explain to our parents too, that if there are other things that we need to kind of deal with urgently, we can do that. We're going to take care of this clubfoot for you too, but that's something that kind of comes down to the provider and counseling.
I'm not sure I'll tell you, probably not like different survey, but you start right away or even several months down the line, it may require more casting. But one of my mentors, Tom's mentors, I teach him, used to tell me that, he had a lot of pearls. He would love to see a child with clubfoot that was delivered rich because he could get the clubfoot cast on for the other thing that he used to emphasize, okay, is the advantage, okay, to like earlier, okay, and even in that neonatal period, sometimes if they're in NICU, they need IV access to be able to get to the feet. But the earlier you cast them, you take advantage of circulating and relaxing. Okay? These kids are definitely more supple early on than 3, 4, 6 weeks later. Okay? He used to tell me, how often should you cast this? Well, typically cast it every week. Is that appropriate? Well, people have done studies looking at collagen relaxation. After you stretch those collagen molecules, okay, there's a relaxation period after 8 hours. After that 8 hours of stretching this, okay, yeah, you could put on another cast, probably get a little bit. Does that, okay? That's the science. I think from a practical standpoint, okay, every week, I'm not sure. But I think one of the other things pointed out, okay, that Dr. Poncetti emphasized, okay, is that, when these kids come back, you don't just have throw them in the pants. You have to spend a couple of minutes stretching them, okay, stretching them appropriately. Imagine after stretching them, he could almost just hold the foot in that position. Okay. He was a master of this. One thing that he never did was he never got x-rays. We didn't talk about x-rays. Okay. I was trained to do x-rays. I still do x-rays, but probably not for my start to see some currents. Very good.
Yeah, it's great then. Sometimes I give the family the option, So, yeah, Dr. Bo does it for the reasons he stated, and I think those make a lot of sense. It takes a little bit of time to get comfortable with the idea of doing it. So in fellowship, there was one of my colleagues, Samantha Spencer, who started to try to do percutaneous tenotomy. She got a lot of pushback from the nursing staff. But what I've kind of learned, and Dr. Twasson and I started doing this, is that you use the emla cream, then you use a tuberculin needle and inject 2% lidocaine in the area that you're gonna do the tenotomy on. And then the kids do not feel the tenotomy, they don't cry, and I can get a good cast on. But I do send the parents out of the room because watching all that and seeing some of the bleeding that takes place can freak them out. But so I palpate it beforehand to make sure I know where my landmarks are when we go in. But Dr. Bo is exactly right.
Well, I can comment on that too. So just coming from a fellowship where we did them routinely in the clinic, there's a major differences between an outpatient setting and a clinic setting that's in the hospital. So if you're in a hospital that's 100 feet from an operating room, in a clinic where they have child life and a very smooth system where they bring patients in ahead of time to put the emla cream on and everything set up for you, and it's almost like you're basically in an OR. And that system, it works. But no, when you're in a busy outpatient office in East Brunswick, in the middle of houses in a residential area with no help, that's a completely different beast. So I think in our region, I think it makes sense to do it in a controlled setting in the operating room where everyone's handing you instruments. So it is doable. I think it has to be basically a very streamlined process in a hospital clinic. And then I think it is doable. But no, in our setting, we're definitely get a better cast, better release when the patient's asleep, in the operating room with our good pediatric anesthesiologist too. I also just wanted to comment to Danika that I think it was a great comprehensive review, of clubfoot just in general. And I think the take home point is that, yes, can it happen that you don't release the Achilles? Sure, you get these cases, but it's certainly not that common. It happens. And I think all of us have been happy every time we've released an Achilles, and we've had cases where we've been unhappy that we did not release an Achilles. So if you do it safely and in a controlled setting, in general, if I can palpate the Achilles, I think it needs to be released. So it's just that rare case. I heard you commenting before, Dr. Bo. Did you get an answer from Poncetti? How often did he do an Achilles tenotomy?
Dr. Bo stepped out.
Dr.
What was that?
Yeah, I think it was Dr. Bo stepped out, but
Okay.
Dr. as far as I've heard, it was up to 90% that he actually performed.
Poncetti was 90%.
Yeah.
Dobbs. Yeah.
Right.
Well, that was great, Danika.
Thank you.
Thanks, Danica. All right. So